Hey everybody, this is Mike. A lot of interesting things going on in healthcare this week. Of course, we woke up this morning, at least the morning that I'm recording this, and the Republican House of Representatives is going to vote on their new healthcare plan today. And as I talked about, the main structural difference from the previous AHCA is that they're going to defer to states a lot on things like the essential benefits and the pre-existing conditions. So that will give a lot of flexibility for local communities to adapt. Now, the counter-argument is that you would be able to get rid of pre-existing conditions, and that would leave a lot of people unprotected. So they were stuck at this point for a few days. But now Fred Upton from Michigan has put in an amendment to have $8 billion for high-risk pools. So these people, if they get knocked out of traditional insurance plans, they would be able to get insurance through these high-risk pools. And of course, the problem is $8 billion over 4 years is incredibly inadequate. Just in 2013, when we were transitioning to the Affordable Care Act, there was about 15 months where we ran these high-risk pools. And we used, in that 15-month time period, we needed $175 billion for the high-risk pool. So $8 billion over 4 years is incredibly inadequate. So lots of political noise about this. What I found more interesting this week was some of the discussion about invisible high-risk pools. And with this whole talk about high-risk pools, this is the slide, and I've showed this many times before. This is the slide that's the problem. What do you do about the 10% of patients who consume 65% of healthcare resources within any given year? Insurers who get stuck with a lot of these patients within the marketplace are going to go out of business, right? So how do you manage this? And the idea is that, well, we have these high-risk pools, but again, the problem is we never fund these. And Maine has some experience recently, and it's been great fun for me. Those of you who know me know that I lived in Maine for 20 years. So it was great fun this past weekend hearing Susan Collins and Angus King and others from my old days in Maine talking about the Maine version of the high-risk pool. And if you're interested in learning a lot more of the details, I'll give a brief overview, but Allenbaugh et al. In Health Affairs had a nice blog about this. But here's how it worked in Maine. And it's not really a high-risk pool. It's kind of a hybrid reinsurance program and high-risk pool. Because it's a reinsurance because it uses predictive analytics to identify those people that are going to have high claims. But then, and once they identify these people, they kind of invisibly, without the patients really knowing, they put them into this high-risk pool. So the patients still see their insurers, but they are asked, all the people in Maine were asked, once they were given insurance, they were asked to complete a health assessment. If that health assessment indicated one of 8 conditions, COPD, endometrial cancer, metastatic cancer, prostate cancer, congestive heart failure, renal failure, rheumatoid arthritis or HIV, the insurers would understand that these are going to be high-cost patients. And so they were automatically, without the patients knowing it, the responsibility for paying their health care bills was moved to this state-run high-risk pool in Maine. The insurer still administered the claims. They were the face, but there was this pass-through to where the state was paying their bills in the background. Okay, and for the administration, the insurer got 10%. 90% of these high-risk patients' premiums went to the high-risk pool. Now, that's not going to be enough, right? And so, every month, everybody who was insured in the state of Maine, $4 of their premium went into this high-risk pool. And between those two funding sources, they were able to fund these invisible high-risk pool. pools. The patients did not feel the stigma of being in a kind of a separate thing. They thought they just had regular insurance, and the insurers were using this as a reinsurance plan. Now, what if, the insurer has a patient, they come in, they're fully healthy, they don't have any of these conditions, but then they are diagnosed with metastatic cancer or HIV or rheumatoid arthritis. Well, the insurer is now acting like a normal insurer. Well, now they have to pay for these unlikely events. So now they can get back into a more normally functioning insurance market where they understand their risks and they can set prices appropriately. But because these high decile consumers are out of the picture, the premiums are much lower. And so Anthem was the largest insurer in Maine, and you can see that their insurance premiums without these high consumers were much lower. So this is an example of something that might work. This is one of the rationales of the ACA, is that we take the experiences within the state and think about how we can expand it to a national level. Now, for those of you who know health services research, that doesn't always work. That if you have a program that improves quality or controls costs in one provider or even in one state, it does not always generalize. So we need to think about this and how this would work at the national level. But it's an interesting idea. What the Republicans are proposing in the House, that's not going to work. That will be stripping away the pre-existing conditions protections for patients with completely inadequate traditional high-risk funding. I have a family member who needs a joint replacement, 83-year-old female, and they are not going to send her to a rehab. They're going to discharge her from the hospital directly home with outpatient rehab. So she's had previous joint replacements, and that's always involved a 6-week stay approximately in a rehab facility, which she didn't like. So she's thrilled to be going home. And for the providers, this is a lower cost option that they've demonstrated is equally effective. So it's a very interesting phenomenon to me. It's a continuation of this deinstitutionalization phenomenon that goes all the way back to the 70s with mental health issues, and it started with the movie with Jack Nicholson, One Flew Over the Cuckoo's Nest. And ever since then, so we had this mass deinstitutionalization of mental health patients, and we see many of them, for those of you who live in large cities, we see a lot of them on the street. So there's debate about, is this a good thing or a bad thing? But it's a thing. But we're also doing this in the rest of the healthcare sector, and we see this a lot. So this will be a cost savings because they don't have to pay for the rehab facility, and so there will be that savings. But are they really saving? Because who's going to take care of that patient? Well, the family will kick in. People will adjust their work. They'll come home in the middle of the workday to check on her and make sure that she's okay. They'll help her with rides, and so you get into this presenteeism. These people are supposed to be working, but they're helping this patient. It's part of the movement to almost back to the colonial days of where an illness was a family responsibility to take care of that. And we're moving back to those days. My point about bringing this up is we don't capture the financial costs of this well. We miss those. What is the cost of presenteeism? For example, when my wife had cancer, she spent 2 years with chemo and radiation therapy. And I continued to work. I don't think I ever missed a class or took a day off. But was I equally as productive? Probably not. But it's very hard to capture that. So we seem to be saving a lot of money, but are we really? I'm not sure. Does it really matter? Yes, obviously using fewer rehab services are good, but a lot of remember on the acute care side, for example, we're discharging these patients faster. And so the hospitals need fewer nurses, they need fewer staff, and that will save them money. Really, does that really happen? Because remember that these acute care facilities and even these chronic care facilities are high fixed cost businesses. And so, every time a patient does not go to a rehab, that doesn't lower the rehab costs. Yeah, the insurer doesn't have to bill for it, but they don't necessarily lay off people. They have, they'll get their patients from somewhere else. So are we really saving money? It's not as clear an issue as is often presented. Finally, just quickly, I saw this. I thought it was interesting. The CDC released this data. Huge parts of the country were getting seatbelt compliance rates in 50%. So with this individual mandate, people don't use seatbelts. This is an issue that's 50 years old. It's going, for people to accept the responsibility of having health insurance, it's going to take many, many decades. Okay. I saw this thing last year. I think it was Massachusetts now has an uninsurance rate of 3%. Really, that's really remarkable. And if you look at Massachusetts, they're in that 50% seatbelt compliance. So what's going on there? This concept of the individual responsibility to gather resources, to provide resources for when they are sick, is a concept that will take generations for Americans to accept. Anyhow, that's some of the things going on this week. I hope you have a great week, everyone.